Welcome everyone to today's program. I am Ayla Ellison, editor with Becker's Hospital Review. The program will begin with a presentation and we will have a question and answer session following completion of the presentation. You can submit any questions you have throughout the presentation by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. You will receive an email within about a week following the webinar that will include instructions for how you can download a copy of the presentation. You will also receive a follow-up email shortly after completion of the program. You can submit your feedback or any additional questions at that time. This email will not include the presentation. It is now my pleasure to introduce today's presenters. Tamara Wagner serves as the Vice President, Performance Review for National Medical Billing Services. Tamara is considered to be one of the strongest coders in the ASC industry. She joined National Medical Billing Services in 2004 and today serves as Vice President of Performance Review. In this position, Tamara is responsible for overseeing the largest coding staff in the country, as well as a client with 65 locations. She also developed a training program for new coders. In addition, Tamara makes sure that she and her team focus on getting extensive continuing education in ASC coding so that all national medical coders stay current with all the trends and changes in the industry. Tamara began her career at SmithKline Clinical Laboratories as a medical technologist. She then moved into various healthcare roles before joining National Medical. She is a frequent speaker at industry conferences, including ASCA and Becker's ASC. Tamara has also contributed numerous industry publications. Allison Cooley is a senior spine coder for National Medical Billing Services. As a certified professional coder for over a decade, Allison is one of the nation's preeminent experts in the field of spine coding. Clients around the country seek out Allison for guidance on complex coding cases. She expanded her expertise when she completed the AAPC requirement for ICD-10 certification and was instrumental in guiding her clients through the daunting transition. Prior to National Medical, Allison worked at Litchfield Hills Orthopedics, where she was a rising star and ran the entire revenue cycle. With her extensive experience of orthopedics and spine, Allison is an expert in process, procedures, and reimbursement methodologies in these complex and ever-changing specialties. She works closely with her clients to make sure they are compliant and understand what is needed to code these cases accurately. Allison has shared her knowledge as a speaker on complex spine and pain coding for Becker's ASC Review and has presented on ICD-10 at a number of industry conferences. Since 2003, Lisa Rock has served as president of National Medical Billing Services, one of the largest ASC billing companies in the country. Lisa is a seasoned healthcare management veteran with over 25 years' experience in the industry. Her wide-ranging background consists of positions such as Director of Training and Education for the largest regional payer in the Mid-Atlantic area for 7 years and Vice President of Business Office Operations for an ASC development and management company for 2 years. She has also managed private practices in the specialties of orthopedics, retina surgery, cardiology, and anesthesia. It is now my pleasure to turn the floor over to Lisa to begin today's presentation.
Thank you very much, and thank you again, and thanks to everyone for listening in. We have a lot of information to cover. We're going to start on the next slide explaining exactly what we're going to cover today, which will be tough pain and spine coding issues, as well as the ever-changing billing issues today. Let's go ahead and jump to the next slide. I think the biggest change today is insurance verification. It is important to do your due diligence up front, but add also who pays. We are in an ever-changing environment with employer groups going self-funded, and that includes medium-sized and small groups as well. And so it's important for us to know who is paying. If we can go to the next slide, please. So right now, about 26% of employers in the small group market are self-insured, but that's changing, about 82% with 500 or more today. And we're seeing this increase at a very rapid pace for a number of reasons. In fact, I'm looking at a white paper that literally just came out from a large employer group targeting medium and small companies basically stating cost relief to employers regardless of size, that if you have 25 employees or more, this company can help you overcome the obstacles that were formerly in the way of small groups going to a self-funded environment. So that's interesting to know, and so we want to today understand who is paying the claim and how it pays. All right. So we have our standard financial classes, but I would recommend adding as a financial class self-funded today. I think it's important to track who is self-funded. There are a number of changes that happen to the summary plan description, and they have nothing to do with the actual carrier, and it's just the way the employer is deciding how a particular type of claim will be paid. And so understanding that environment today is critical to knowing your net revenue. One more thing, as you're verifying insurance, a lot of surgery centers rely on the professional authorization, and today that's just not good enough. You really should call yourselves and get your own authorization. I'll give you one example as to why. Let's say the professional side is participating in that particular carrier's plan, and the ASC is out of network. When the professional calls to get authorization requirements, they're calling from an in-network professional group, and there is a distinction sometimes with set auth requirements, and so you might get a no, this procedure doesn't require an authorization. However, the facility, being a facility and perhaps being out of network, may require an auth for that particular procedure. So I would definitely do 2 separate authorizations. Also, make sure, this is kind of old news, but we're still seeing a lot of errors across the country with this. Get the accurate CPT codes or a proper range of CPT codes to get that coverage. It's getting tougher and tougher to get those retro authorizations approved. This is an example of an insurance verification authorization form. Just so I throw that in here. This is what throw that in here. This is what we use. And then some samples of self-funded groups and how they pay out of network. We used to use ERISA.gov. We haven't been able to get on that website. I haven't had a chance to find out why. In this particular instance, we went straight to the benefits page on American Airlines website. And effective June 1st last year, American Airline employees out of network will have an allowed amount of 140% of Medicare. And I also, on the next slide, showed you Disney, large employer. They're around 200% of Medicare, if there's Medicare crossover. And then the next slide, FedEx. They're actually not a percent of Medicare today. They're usual and customary, and this is the type of reimbursement out of network that would reimburse at a much higher level than the percent of Medicare. So closer to your billed charges, if your billed charges are somewhere, hovering around, 5 to 7x of Medicare using Fair Health, maybe in the 50th to 70th percentile. And then we also have out-of-network still around some maximum benefits. So this one is actually, I think, $1,500 per day maximum benefit. The rest of the employee or member or patient would owe. And so that's at the beginning. And I know I packed a lot of information for you, and I'm going to come back to that towards the end. We're going to get into right now some difficult coding issues, first for pain and then spine, and then we're going to circle back on some more of these billing issues that I'm seeing today. So Tamara, with that, why don't you walk us through the next few slides?
Sure. Good afternoon. Starting on this slide, for pain and spine, the most important thing for a coder is to be familiar with the anatomy as well as the code sets. You must understand the spine anatomy in order to be a successful coder. You need to understand what approach the doctor is doing. You need to know your proper level assignment when it comes to assigning levels for your injections, specifically your medial branch blocks or facet joints or your RFAs, based on those nerves that are being treated. And then, of course, correctly assign your CPT and diagnoses. Next slide, please. This slide should be in the Coder's Bible, actually, if you are a pain management coder. On the left-hand side, it shows you transforaminal epidural injections, and then for the right side, it shows your facet joint injections. And being familiar with the anatomy, like I stated earlier, is so important, because you end up with your medial branch blocks, your facet joint injections. You have a C8 nerve, which then for your spine anatomy pushes down everything, as I like to say, to a different level. Many times we have difficulty with our operative notes because the levels and the nerves are not accurately documented. So if you're a coder out there, please refer to this chart. It is very helpful. The next couple of slides are just showing anatomy of the spine. We won't dwell on this, but just wanted to throw those in there for a visual. Next, we're going to move on to documentation challenges. This slide is an example of how important it is to obtain accurate and detailed documentation. As you note, on the header of this slide, we have a left laterality, and then as we get into the body of the description of procedure, we have bilateral. So it's so important to make sure you have a compliant note at all sections of the note. We have discrepancies here between the procedure heading and the actual description. If you don't go back and do an MD query, you may be leaving revenue on the table if you're not accurately reporting what procedures were performed. Next slide. This is an example of proper documentation for a medial branch block. It documents at what levels the needles are being placed to access the appropriate nerves. And then the next slide is just another example of a cervical medial branch block with the proper documentation. So if anytime you have any kind of question regarding the documentation, go back to your provider and get that clarification so that your documentation includes all of the levels that are being performed. Allison?
So Allison, you're going to walk us through some of the documentation challenges for spine, right?
Yes, I am. Good afternoon. One of the biggest spine surgery documentation challenges that we've found and have been finding is decompression documentation, specifying levels versus nerves. Documentation for decompression should indicate the specific nerves being decompressed at that level. For example, if they're doing an L4-5 decompression, are they decompressing both the exiting and the traversing nerve root? If they are, they should specifically state that, because then you can bill 2 levels of decompression versus them just saying they decompressed L4-5, which would only give you 1 level of decompression, because you're not specifically telling the carrier that you're doing 2 separate nerves decompression at that level. This is a very common problem, because a lot of times the physicians just assume that if they say L4-5, they're going to get 2 levels of decompression, but it's billed by the nerves decompressed, not by the amount of bone work you do. On the next slide is an example of proper decompression documentation. This note was sent to us, and it adequately describes this physician decompressing the nerves at L3, L4, and L5. He specifically states he decompressed each nerve bilaterally around the pedicles and into the foramen. This is spectacular because you can bill for 3 levels of decompression for this note, whereas if he had just said that he decompressed L3, 4, and L4, 5, you would have only gotten 2 levels of decompression. Next.
This slide's an example. We just wanted to put a slide in there regarding what we call vendor pressure. This is for a particular procedure that the vendor is stating you will be reimbursed if you code as this CPT code. But what you want to be very careful about is if your documentation and the procedure performed are actually meeting what is required for that CPT code to be reported. There's so many vendors out there wanting to sell their products, and so they're informing the providers that they can bill as, you know, CPT code 1, 2, 3, 4, 5, when actually it should be 5, 6, 7, 8, 9.
I think that's really good advice, Tamara, because I mean, I have seen this my entire career where salesmen will come in and talk about a particular technology or new technology and recommend certain codes, and the reimbursement looks amazing in the marketing slicks. And then when you sit down with your coders and find out that you can't use those codes, well, you might be able to use them, but you're at risk for takebacks at some point. You want to make sure that you vet out everything that the implant companies are giving you as far as coding is concerned. I don't think they're doing it intentionally. I think they really believe that these codes are accurate. When you get an opinion that's different than the implant companies, then get a third opinion and just make sure that all parties involved are citing legitimate sources to back up their opinion. And like I said, this is a really good example because this went all the way to the CEO of that particular firm.
And if you're a coder, refer to CPT. Many times they publish CPT assistance about, you know, somebody will send in a question and they'll answer it with the appropriate code that should be used.
Now we're going to talk about LCDs, NCDs, and payer policies. It's very confusing because, I mean, the first question we get is how often are these things updated? Well, we know some of them are annually, but remember, annually by code means that it changes every day. Something is changing all the time. Just because you hear that a payer policy is being updated annually doesn't mean you only have to look at that payer once a year. It means that particular service is being reviewed. And then they could have another one the next day and the next day and so on and so forth. So you have to figure out a way to stay on top of all of these changes. A lot of the software systems will have the LCDs and NCDs embedded in them, but the payer policies can be very tricky. And with that, Tamara, you want to walk us through this?
Right. The payer policies are diagnosis-driven. You know, they typically list ICD-10 codes that will meet medical necessity based on the CPT code. But medical necessity also means frequency of injections. Are your providers following that? If they're performing too many injections in a given time frame, they may be denied. You want to make sure you have progress of treatment that needs to be included in the operative note. And sometimes the carrier policies might even contradict what's deemed medically necessary within their own policy. And then make sure you have good communication between your ASC and your providers. Like I said, next slide, sorry. Example of carrier policy requirements to support medical necessity, especially in the pain management and spine world. You know, do they document 3 to 6 months of conservative treatment? Do they have specific percentages of the pain relief for the previous injections, procedures performed? Was there prior physical therapy? Are they on medication therapy? And then MRI findings. These requirements are all needed in your operative note to support medical necessity. The next slide is just an example of a Medicare LCD versus a commercial payer policy, just to show the difference for a medial branch block, what ICD-10 codes are meeting medical necessity for a medial branch block. As you can see, they don't match. You know, some payers have a smaller list. Other payers might have a list that is several pages long if you print out their policy.
This is a good example of why you can't use LCDs across the board for all patients. You just can't. You're going to, if you do not know each of your commercial payer policies, and again, they change all the time, if you don't know them, then you are going to have an issue. The first thing that most payers are going to do if they see one of these diagnosis codes, or a diagnosis code that's not on the list used, is ask for medical records. And I'll bet if you're in pain management and spine, you've seen an increase, a substantial increase in the request of medical records post ICD-10. We have across the country. And this is contributing to that. So making sure you understand all of these different, and again, you know, if you're a surgeon circling a ICD-10 code on a, you know, super bill or an EHR, and not understanding that, you know, there are differences in the medical necessity coverage, then it's probably a good idea to pull as many as you can and do it at least once a quarter. Okay. Got it. So on this next slide, this is interesting. This is an example of a payer policy, and one of the big ones contradicting itself. So it took us a very long time to get this payer policy, medical necessity policy, and this is from Medial Branch Block. And in red, we've highlighted the contradiction. So the therapeutic facet joint injection is unproven for the treatment of chronic spinal pain. And then when you go down to the bottom, they are quoting ACIP and the suggested frequency and treatment. And so in this particular instance, it's interesting. Some of our claims were paying and some of them weren't. Well, this will tell you exactly why some of them were paying and some of them, and this is, again, same diagnosis, same procedure, same surgeon in this case, and to get this payer policy was very, very difficult, and then we figured out why our claims were being denied, and we were able to work with the carrier on all of the unpaid claims, but getting to this point was very difficult, so we're happy to share this with you, that this is the kind of stuff that's going on out there that is getting in your way of getting paid. Tamara, you want to walk us through?
Sure. This next slide is an example of 3 different types of procedures based on Medicare's LCDs. It's just showing you the frequencies of the procedures. Just wanted to put that in there to show you all of the information that you will find in your LCDs. And it's very, very important that as coders we know these policies and we share this information with the providers. The next slide is an example of 3 different Medicare contractors for an epidural injection, just showing how they differ in their frequencies.
Now, for those of you that are just using one intermediary, then this probably isn't going to impact you as much. But if you're talking to someone about a Medicare policy, understand that if you're talking to someone with a different intermediary, you might not be getting the right advice. So, or for those of you that have national companies, your intermediaries could possibly have different LCDs, and this is an example of one.
This is just another example as well. This is for medial branch blocks, just showing the different Medicare contractors and the difference in their policy.
And these are really different.
Right.
These aren't just slightly different. These are very different. So.
And just one more slide regarding the differences for RFAs based on carrier LCDs.
Allison, would you like to walk us through physician responsibilities?
Absolutely. physicians really should ensure that the medical necessity is being met and documented, not only in the operative notes, but in their office notes to support the procedures being ordered and the procedures being done on the patients. This is where conversations with physicians comes in important, because they have to know what the carriers expect for medical necessity, because they may vary slightly from carrier to carrier what they consider conservative treatment versus what type of documentation they require for medical necessity, what they want to see in an MRI report, how many weeks of physical therapy, those kinds of things. Physicians should stay on top of medical policy changes by carrier, which again, communication with your physician is of utmost importance, so that you can keep them advised of the changes and you can keep them advised by carrier. They are not going to have the time really to stay on top of the medical policies. It's our job to make sure that they understand. And then it is a physician responsibility to circle back with the front desk once the authorization is done. If the physician deems that he's going to need to change the procedure being done, or that he's going to be doing an additional level, or somehow altering the procedure that was authorized, he should communicate that to the front desk prior to the procedure being done, so that the front desk can add that information to the authorization and keep the authorization current. There are always times when the physician will get in there and he may need to do something additional or something different based on what he's seeing once he gets in and starts the procedure. That's something a little bit different, and that's something that you can discuss with your carrier after the fact and send in the documentation. But if he knows he's going to be changing something ahead of time, he really should advise the front desk so that authorizations can be updated or changed as necessary.
Well, I know you're going to fill us in on the spine coating implants, and I know you have actually one that we hear a lot of different information about. I know when I'm out at these conferences, I hear very different things about the first one. So would you like to shed some light on what the confusion is?
Yeah, P-stim, which is called auriculotherapy, is a tiny little, if we can back up just one slide, Scott. This little device being placed behind the patient's ear is what's called P-stim or NeuroStim. It's an auriculotherapy device. You can advance to the next one, please. Designed to stop chronic pain, and a lot of physicians now are using it for post-operative pain. What they do is they stick this little kidney-shaped transmitter behind the patient's ear with 3 little wires that attach to nerves in the ear to stimulate those nerves and alleviate post-operative or chronic pain. P-stim, the vendors were originally suggesting that you use CPT 64555, which is a percutaneous peripheral nerve stimulator, and L8680 to bill for the device. However, it is not; those are not electrodes, implanted electrodes, nor is this an implantable device. CPT Assistant on the next page specifically states that this procedure should be billed as unlisted, and states further it would not be appropriate to report 64555, percutaneous implantation of neurostimulator electrode peripheral nerve, as this code is for implanted directly into the body nerve stimulator. This is where searching your CPT assistance and knowing payer policies, many payer policies address this particular item by name and state that it should be billed as unlisted. So you always want to make sure that you're researching any kind of new technology being brought into your facility, so that you're finding any kind of official sources that are guiding you in the correct coding of these particular new items that are being brought into your facilities. On the next slide is another new, it's not new, it's been around for a little while, but it's getting more and more popular. The interspinous process distraction, devices for stenosis. There are 2 different types. There is the type where you just insert the device and it creates an indirect stenosis by lifting up the vertebral bodies and relieving the pressure on the nerves. And then there is one where the physician has to do an actual decompression, laminectomy, facetectomy, foraminotomy, and then he implants this device to keep that channel open so it keeps the stenosis at bay. Now, this particular device is very complicated at this point because you have three different factions telling you three different ways of coding. The vendor is suggesting 63047, which is a decompression code, with 22840, which is a posterior non-segmental hardware. However, the device itself doesn't span the vertebral bodies. It actually goes in between them. So according to Medicare, they're following CPT Assistant, which is coding this as 0171T. According to NAS, they're thinking 22899 for the unlisted, for the insertion of the device. On the next slide is some of NAS's responses to the actual questions regarding this procedure. They do not believe 22840 is appropriate because it is not considered posterior spinous hardware. They believe 22899 is the correct way to report the insertion of the device itself. As for the procedure, they don't believe that 0171T is correct because it doesn't address the direct decompression that your physician has to do before they can actually insert the device. But on the next page is a CPT Assistant article that was published in direct relation to a question regarding this exact device. So you can see there are many varying opinions on how to report this specific procedure. You have societies weighing in, you have CPT Assistant weighing in, and you have the vendor weighing in. So you really do have to do a lot of research to get to the correct way to code this particular item or any new device or technology that's coming into your facilities.
Right.
The next, we have some coding issues regarding approaches and new technologies for spine surgery coding. Again, as Tamara mentioned earlier, the approach that the physician is making is very important because a lot of the codes in spine surgery are based on the approach that the surgeon is making. There are anterior codes, posterior codes, presacral codes. Below are examples of some different types of approach codes. For example, interbody fusion in the lumbar spine, anteriorly would be 22558, whereas posterior with just the interbody would be 22630, and with interbody and posterior combined is 22633. Instrumentation codes are another example of where the approach the surgeon is using comes in very important because they are also set up by anterior versus posterior hardware. So you need to know, how the surgeon is making his approach in order to be able to choose the appropriate codes for that area. On the next slide, there's a lot of technology changing how these procedures are being done. There's a lot of minimally invasive approaches versus the gold standard open approach, and now there are endoscopic procedures being done. So the physician's going to want to clearly document, and if it's not clear to you, please by all means query your physician so that you're choosing the appropriate codes. According to NAS and AMA, if they can visualize it with their naked eye or their loops or a microscope, operating microscope, it's considered an open procedure, even if it's done through a minimally invasive tubular retractor. The minute they go into endoscopic, that has its own CPT codes and should not be coded as an open procedure at that point. So you're going to want to read the documentation very carefully and make sure to see if the physician is truly stating, was this an open approach? Was this an endoscopic procedure? Did he do this open? Did he do it through a tubular retractor? As I said, querying your physician if you're unclear about the note will help you choose the correct CPT codes. Can we move to the next slide? There's been new implant creations over the past few years. For instance, the gold standard in inner body was either a peak spacer or a cage, which is a synthetic, which would be coded 22851, or if you're using a bone spacer, it's 20931, with an anterior cervical plate and screws, which would be CPT 22845. Now, those are separate instruments. The peak spacer is separate from the plate and the screws, which span the exterior of the vertebral bodies. There have been standalone inner body spacers, which is a peak spacer and screws all in one. It doesn't have a separate plate attached to the external vertebral bodies. These are billed as CPT 22851 only because there's not a separate plate and screws spanning the exterior of the vertebral bodies. On the next slide, there is an FDA publication regarding these standalone inner body devices where NASS came out and stated the same position, that it would be coded only as 22851. An additional instrumentation code 22845 is not applicable because there is not a separate construct placed across the vertebral segment. And the AAPC followed suit on NASS's position. So far, this has not been changed in any way. They still stand by this position, and my understanding is that in 2017 they're hoping that CPT will address this specifically and put in wording either in the 22851 or create a new code specifically for the standalone inner body devices, so there will be less confusion. On the next page, we talked about knowing what type of implants the physician is using. For example, you want to make sure whether your physician in the cervical spine is using the standalone inner body device or whether he's using the cervical plate with the screws, so that you know whether you're coding both the anterior hardware and the inner body, or whether it's only one code for the standalone. Here are some examples of where unlisted versus T codes come into play. Interspinous fusion devices are an unlisted item in every payer policy. Decompression devices, such as the ones we mentioned before, were under CPT code 0171T. Now, 0171T is being sunsetted in 2017, and my understanding is that it's going to be created as two new CPT codes, one for inserting this device with direct decompression and one for inserting this device without direct decompression, which will hopefully also alleviate any kind of confusion. But you definitely want to research payer policy and any kind of CPT assistant you can get your hands on regarding any new technologies to make sure that you're using the correct codes to report these items.
Okay, thank you, Allison, and thank you, Tamara. I'm going to run through the rest of the slides quickly on the billing portion. First of all, next slide, EDI. Looking at your rejections every single day will improve your cash flow. You already know that, but you can actually pull reports out of your system that will show you a first pass clean claims rate. And you want to get that first pass clean claims rate up over 95%. So anything less than that, you probably have some demographic entry issues, which we still see as the #1 reason for denials today. You can also submit workers' comp. Today you probably know this, and then your EDI company, your electronic data interchange company, can attach the records on the back end for you. And at least you would have a record of submission that way. The next page is an example of what the reports look like out of one of the EDI companies. This is really good information. It's a quick report you can do once a week or once a month and add it to your financial reporting package. The next slide, denials management. Most of these you're aware of, but I've added some new ones to this. The routine waiver of patient responsibility. I've also added underpaid claims as a denial because that's what it is. And I know folks tend not to work if it's been paid, but If it is underpaid, you have to look at it as a denial because you're not getting your full net revenue. Non-disclosure of out-of-network status, I'm going to get into that a little bit. I've added as a reason code, and then monitoring all of these denials and getting them under control. Again, the medical necessity denials I've seen increase substantially since implementation of ICD-10 last year for pain management and fines. Moving on to negative balance invoicing or carrier takebacks. When you get your take-back request from the carrier, you want to call immediately and notify them that you're investigating it so that it doesn't automatically happen. It might not be legal to do in your state. You might have to write a refund check if you truly owe it, but the point is to look at the request and make sure that it's a valid request. Sometimes it's a coding difference. And a lot of times they're not right with their coding opinion. So if you see that it's a coding issue, definitely outsource that and get a couple of opinions so that you can fight it. I'm going to talk a little bit about the out-of-network environment right now because so many surgeries are still partially out-of-network. From the carrier's point of view, I think the toughest issue we have right now is waiving any part of the patient responsibility. There are a number of high-profile lawsuits going on right now, one that was just settled out in California that was a substantial hit for the ASC. So having a good patient collections policy, an internal patient collections policy in place today is much more important than it ever has been in the past. I think the days of notifying payers on your claim forms that you're going to adjust the claim, I think those days are gone. I think that the days of just submitting 3 bills as your attempt to collect, if you're not actually collecting anything, those days are gone. You have to figure this one out. And I think properly categorizing your patients, for example, the financially indigent, using some formula, matching federal poverty guidelines, and also under healthcare reform, medically indigent is a proper way to write off, and getting those off the table, I think, leaves you the rest as a landscape. And like I said, this is just a hot issue right now, and I think you really have to figure out the patient portion. And it's tough, right, because not all states have any willing provider law, so you might be in a state where the network's closed, and even if you wanted to get a network, you can't. And if you are able to get a network, sometimes the contracts that are being offered right now are less than Medicare, maybe even substantially lower than Medicare, maybe 30% of Medicare is what I'm seeing in some cases. So I think paying attention to this right now to protect your revenue is critical. What we're seeing is this maximum allowed amount on out-of-network claims, and this is basically a percent of Medicare plan. A lot of the out-of-network claims that are paid by self-funded employers are beginning to trend to follow Medicare. So the examples that I gave at the front, American Airlines at 140%, and some of the other companies at a percent of Medicare, and there are there's information on Fair Health's website about out-of-network and sort of pushing patients to stay in the in-network arena to cut costs, and also to employers to look at this piece in their summary plan description and contain costs. Let's go ahead and move to the next slide. From the provider's point of view, out of network, very quickly, to accept a contract that's less than Medicare would be financially devastating. It really would be. And so what can you do if you fall into that situation that I just described? I think that this is something that you have to put a lot of time and effort into figuring out, hiring professionals for the different avenues to help you figure out a good plan so that you're not in a position where you're crossing this bridge 2, 3, 4 years later and you're looking at take-backs and other issues. In some instances, the carriers are taking, pardon me, they're not taking, they're not paying the insurance portion of the claim until you collect the patient responsibility. We're seeing that quite a bit right now. And so it goes without saying you absolutely have to address this patient responsibility today. On the next slide, designing a state-of-the-art patient registration packet. Today you want your AOB or your assignment of benefits form to include ERISA language so that we can appeal if there is an underpaid claim. Because the self-funded plans are governed by ERISA, this is the way we need to appeal today. And we need to have that ERISA language, which basically gives the provider the right or the privilege to appeal on behalf of the patient and follow that course. And the old way of doing things is fine in certain circumstances, which means setting a regular appeal. We underpaid, this is the market value, that sort of thing. That will still work in certain circumstances, but with self-funded plans, you really need to have an AOB. And sometimes the carriers will require the AOB to be signed post-operatively. And so look for that as well. And I've discussed the legal writing off of financial hardship, and we'll move on to working on the back end. Organizing the denials in such a way where you can manage on the front end is key. Once you figure that out, your cash will go up. But appealing account by account by account, you're never going to get it done. You can't staff enough people to do that. So you have to look for a trend and then fix that on the front end, whatever it is. And look for those low ends. Look for those back-end negotiations and look for trends in what you're doing. But understanding the environment today as it stands is key to improving your cash. And I mentioned before, figuring out the patient responsibility right now, not just for compliance reasons, but your insurance checks are dropping, most likely your patient responsibility due to the increase in deductibles and co-insurances is something that we can't ignore. And it's pretty substantial. It's projected, the patient responsibility is projected to hit 40% in the coming year. So we have to look at this and have a good plan in place. Also, using patient portals, we have to figure out ways to do this and reduce staffing costs because it's expensive to manage in this environment. So using technology wherever we can, allowing patients to go in to a patient portal does a couple of things. It contributes to transparency, and it allows the patient to pay or query via email and much more efficient. So you're not going to have someone on the phone all day long trying to answer questions. So we had a lot of information to cover, and I think you might have a couple of questions for us. That's the presentation.
Well, thank you to our presenters for a very informative and enjoyable presentation. We will now begin the Q&A portion of the program. As a reminder, you can submit any questions you have by typing them into your control panel in the space labeled Enter a Question for Staff and clicking Send. Our presenters will attempt to answer as many questions as they can during the time we have for Q&A, and will follow up on questions they do not have the opportunity to address. So we'll go ahead and jump into the questions now. And the first one is, what are the appropriate codes to bill a temporary nerve stimulator in the lumbar spine? Do you bill for the lead separately from the facility fee?
Allison, I think that would be directed to you.
If the leads are being placed percutaneously, you would use CPT code 63650 for each lead being placed. And if you're billing for the ASC, unless it's Medicare in most cases, yes, you would bill for the L8680 for the leads separately.
Thank you, Allison. And moving on to the next question, it is our pain management physician is stating NSS in all of his documentation, and the rep is saying to bill 64555. He is not calling it a P-stim in the medical records. This device is being used for pain management purposes and is performed 6 times. They are placing the electrodes in the nerve. We are questioning this based on a conference with Marblehammer and the pain doctor.
So that Tamara or Allison, either one of you can address that. What do you think?
Allison, it sounds like a P-stim.
Yeah, it does. It actually sounds like they're calling them P-stim or they're calling them neurostim without seeing an operative report or knowing what exactly he's using. It would be kind of difficult to answer that, but it does sound like he's talking about P-stim/neurostim, which is an auricular therapy. It would depend. Is he placing it behind the ear with the electrodes going into the nerves in the ear? Or is he actually placing this on a peripheral nerve? But it really does sound like P-stim or /neurostim, which would be the unlisted code.
Okay, great, thank you. And moving on to the next question, it is, are there any specific guidelines or laws as a standard for self-pay patients, uniformity, etc.?
That's a really good question. My recommendation is that you adjust your self-pay rate to equal whatever the cost would be to attempt to collect all of it, if that makes sense. So if your cost to collect is 20%, then I think doing a prompt pay discount of 20% is reasonable. And that's what most of the experts out there would recommend. I think we're all singing the same tune with respect to that. When you start getting into the deep discounts of 60, 70%, or you're using Medicare as your basis for adjusting, I think that could be problematic. I would use cost as a reason to discount for self-pay.
Okay, thank you very much. And moving on, the next question is the out-of-network waiving of deductible and out-of-pocket being seen as a violation to the Anti-Kickback False Claims Act, a state-to-state issue, or nationwide?
Well, I mean, I would absolutely check with your attorneys because there are state laws as well, and I'm not sure what state you're in. So, for example, in Texas, you cannot waive co-pays and deductibles of any kind, and a lot of states have laws like that on the books. So that's number one. Waiving of co-pays and deductibles out of network can absolutely be construed as enticing patients to come see you. There's no doubt, and this is the argument that the carriers are using even today with numerous lawsuits across the country. Having a solid patient collections policy in place and showing an attempt to collect, I don't know another way around it today. I just don't. Not from what I've seen. Like I've said, I've seen carriers actually stop paying and prove that you've collected, and it can be devastating. And if you're saying, well, I haven't seen that in my neck of the woods, well, just Google. It's all over the country, and there are numerous examples everywhere. And again, appealing is tough too. If you're going to appeal and really push the envelope when you appeal and when you invoke ERISA, you're basically ready to go down that legal road. You have to have your house in order before you push that hard. So that is my advice when it comes to waiving of out-of-network copays and deductibles today. I would have answered it much differently 5 or 10 years ago, maybe even 2 years ago, but today it's a tough market.
Well, thank you. And moving on, there are a lot of questions coming in, so that's great. The next question is, if 2 SDS leads are replaced, should 63663 be billed twice?
No, that code is plural, so therefore if you're replacing 2 leads, you can only report the code 63663 one time. And I believe that's also in a CPT assistant.
Okay, and following up with that, can you give clarification on 63047 coding on XG nerve roots in a single interspace?
Yeah, a single interspace has an exiting and a traversing nerve root. So there's one nerve root that crosses across the disc and exits out the next level down. So each interspace has an exiting from the level above and a traversing that crosses that. The physician can decompress both the exiting and the traversing nerve root at one level and code for 2 levels of decompression.
Thank you very much. And when there is conflict of opinion between NAS and CPT assistant, which is the standard to follow? Does CPT/AMA have final say?
I think most people will go with CPT assistant, but you can. I think it would be really up to your provider, because NAS is a recognized source for coding information, and they do a lot with CPT and with the RUC committee, creating codes and establishing codes. And a lot of payer policies will take society direction when it comes to proper coding on certain things.
Okay.
That was a good answer, Allison.
No, go ahead. And moving on to the next question, it is, for removal of spinal cord stimulator, would you code both 63688 and 63661?
Yes, well, and 63688 is for the removal of the actual generator, and then the leads, the removal of 63661. You need to be careful. I find sometimes they want to pull the leads through the generator pocket. So if they're not doing a separate incision for the removal of the leads, but they're still removing the leads through the actual generator pocket, you can append a 52 modifier to 63661 for that reduced services.
Well, I think that's about time, all the time we have today for questions. But I want to again thank our presenters for their excellent presentation and all of you for participating today. We look forward to having you join us for future webinars. This concludes today's program, and have a wonderful afternoon.